So this is regarding the COVID vaccination, which is all a known activity for the entire nation. And Tamil Nadu, we face certain obstacles in this vaccination program. And so we took, with the guidance of the Honorable Minister for Medical and Family Welfare on Principal Secretary Health, we took certain innovations to achieve the vaccination percentage in Tamil Nadu. I'll just run through the slides here. And my structure of presentation will be on mainly on two aspects. One is on COVID-19 current status, the global, country, and the state perspective, and then the COVID vaccination. On the current status, the public response to COVID vaccination, what are the important events we had in this COVID vaccination schedules, and the current status, what is the state performance of the current status, and what are the challenges the state faced. Especially Tamil Nadu is very good in its all health indicators. There are challenges we face in vaccination schedules. And what about the vaccine equity for the state of Tamil Nadu and the innovations, which the prime objective of the entire presentation for all about the current status of COVID-19. It is globally as on, because I'm updated the data on 7th November. I request request of an request for this because I'm with a common review mission or the government of India team, so I was unable to update the nearest data of 10th or 9th. So I'm just updated the data of 11th of November 2022, which I sent to the SKOCH group also. So as of now, 7th of November, we have more than 92 crore cases been confirmed as COVID-19 globally, and more than 65 lakh deaths reported WHO. When compared to India, we have about 4.4 cases confirmed of COVID reported to the WHO, and also 5.3 lakh deaths reported to WHO. And these are the dashboard for the entire state of Tamil Nadu. We have about total 35.92 lakh positive cases of COVID reported, tested and positive, and recovered is about more than 95%, 98% recovered, about 35.53 lakh cases recovered. And at present, active cases around 900 cases are active at present. And the total deaths we reported to Government of India is about 38,048. And the advantage in Tamil Nadu, we have the more number of network laboratories, more than 347 laboratories, and out of which 78 laboratories are in from the government side, and 216 laboratories on from the private side. And the demographic profile of the positive cases found to be male 53, female 53, and the current status of the cases discharged and death as on 7/12/2000 November 7th is about deaths we are not reporting as of now. And with regard to discharges, we have more than 1,500 cases being discharged in the month of November on average. And cases, we are reporting only 800 to 900 cases per day. And the weekly testing about it, we are monitoring on a weekly testing basis and weekly average cases also. Weekly average cases is about only 8,000 around because of the less number of cases being reported right now. And the weekly confirmation is about only 1.5% at present. And good is we not reported any deaths, and we had any no deaths in the last since September. And average new cases about 125 cases. And regarding the COVID vaccination, which is a known activity for the entire nation, and globally, more than 1,280 crores vaccine doses have been administered till date. And India, we are done with 219 crores vaccine doses have been administered, both first dose, second dose, and the precautionary doses. With regard to Tamil Nadu, we are done with 12.76 crore vaccine doses have been administered in a span of 1.5 years, 18 months. This data is updated based upon on 8th of November 2022. And what is the public health response to COVID? And of course, vaccines are not new to any country. Of course, all countries have the vaccination schedules and the routine immunization, as well as special immunization programs also. And what we think is about is a key component of any primary healthcare and an indisputable human right. So vaccines are indisputable human right to any community. And one of the best health investments money can buy is only by vaccinations for future well-being. And to just give a short picture about what are the vaccines we have and what are the platforms we have. Vaccinations, we have two platforms mostly. One is a component vaccines, and another one is whole virus vaccines. And we know the list of vaccines which have been developed by India, various other countries also, and which is available in the country. We have mostly we have the whole virus vaccines and the component viral vaccines. And at present, the track of vaccines, we can go about 49 approved vaccines in the entire global scenario, and out of which 201 countries have approved vaccines. And WHO has given the emergency approval for more than 11 vaccines, and still vaccines are in trial. For example, nasal vaccines is all under trial with now. And these are the vaccines which we are when the government of India has approved for sale in the country is about two vaccines. One is Covaxin, other one is Covishield. Although there are many other vaccines available in the country, the government of India has approved only for manufacture and sale is only for two vaccines, Covishield and Covaxin. And other things and all restricted the use in emergency situations. There are a lot of vaccines, about more than 12 vaccines are available. Sorry, more than 15 vaccines are available apart from Covishield and Covaxin. And but we are the government schedule is only following only three vaccines. One is Covishield, Covaxin, as well as Corbevax. And this is Corbevax again for precaution doses. And what are the important events happened in COVID vaccination? These are the 6 phases of COVID vaccination which we started immediately after the pandemic. The pandemic was declared on March 7, 2020, and the vaccines were available for us, and we started the vaccination entirely in the 16th of January 2021. And as I rightly said, it started in various phases. The phase one started, phase two, phase three, phase four, phase six. The phase one, the government of India, it's all based on the government of India operation guidelines issued by Minister of Health and Family Welfare, government of India. We started on 16th January 2021 for the healthcare workers, and then we moved to the on 2nd February we went to frontline workers, which is giving much importance to the healthcare workers and the frontline workers. And then on March 1st onwards, we started for above 60 years and 45 to 15 years with comorbidities, with a listed 20 comorbidities. And 1st April onwards, we started for every 45 all persons above 45 years, irrespective of comorbidities. And 1st May onwards, we started for all 18 years above. And in Tamil Nadu, we started on May 20. Although Government of India started on given the instructions to start on May 1st, we started May 20, inaugurated by the Honorable Chief Minister of Tamil Nadu. And on 21st June, we made free vaccines to all persons. That is a historical moment. Vaccines were made free for all persons above 18 years. And on 3rd January, we started for adolescents in 15 to 17 years. And 10th January, we started the precaution doses. And 16th March, we started for the 12 to 14 years. So the entire gamut from 12 years, above 12 years, the entire COVID vaccination has been started from March 2022. So all population above 12 years are now vaccinated, and the percentage of vaccination, I'll just run to the next slides. So these are the events which I told in various phases. I run through the slides here, and the most important is Hardas campaign, which I'm telling about in the innovation schedules. And the current performance, at present, we have received about more than 11 crore vaccines. 11.9 crore vaccines have been supplied by government of government of India, as well as we also procured about 10% of the vaccines from Tamil Nadu through Medical Service Corporation with its own state budget. And we vaccinated in the government COVID vaccine centers as well as the private COVID vaccine centers. GCVC stands for Government COVID Vaccine Centers, and PCVC stands for Private Vaccination COVID Centers. So the vaccines been supplied more than 12.17, including the private vaccines, which which the private hospitals were allowed to procure the vaccines from the manufacturers directly, and it included even we also supplied certain vaccines to private hospitals. And later part there was a vaccine demand aggregation policy, liberalization policy of vaccinations. So the private hospitals also they procure the vaccines, and as of now, totally Tamil Nadu got about 12.17 crore vaccines supplied, and out of which 12.76 crores vaccinations doses has been done. And this is because there are vaccines we can get, although it's a 10 doses vial or a 20 doses vial, always we're able to go for with some 10 doses vial, we can go with 12 doses, and 20 doses vial, we can go with 22 doses or 23 doses, because of the 16% additional vaccine doses available in the ampules, in the vials. And this is a status from January 16 we started about till May 7th, we had an average of 61,000 doses only in Tamil Nadu per year, per day. And the wastage, I just want to highlight over there, the wastage we admitted to the government of India, that wastage is about 6%. And this wastage is completely attributed both to the challenges what we faced in the system for COVID vaccination. And later part, we took this initiation in innovations, which I'm going to present in the later part of the slide. And then the average per dose vaccine was raised to 2.17 crore. And again, the wastage, we reduced it to minus 0.70. So these are the achievements in the first dose and second dose. The first dose above 18 years, we achieved more than 96.6%, and the second dose is about 91.66% above 18 years group. Coming to the 15 to 18 years group, with a population about 33,046 lakh population of 15 to 18 years, we are able to come out with 91.34% of the first dose, and the second dose runs about only 77.86. And 12 to 14 years, again, is what is a great challenge in motivating the school children to get vaccinated. And out of 21 lakh population, we're able to go with 94.53% of the first dose and 77.27% of the second doses. Whereas still Tamil Nadu and many other states also having certain dues also, and do mean yet to get vaccinated. There are certain proportions in the first dose due in the 18 above 18 years also, and also we have first dose due among the 15 to 17 years, and also in the 12 to 14 years. We are trying all that efforts to make them to get vaccinated. Although the cases are less reported right now, even the requirement and the necessity for vaccinations or the interest for the vaccinations is reduced right now. But anyway, we are making our own BCC activities so that the entire population and also the vaccine should not get wasted. We are making the entire vaccination again happening in the system. And what are the challenges we faced? I just told that vaccination we had. Of course, Tamil Nadu is one of the state with all health indicators next to Kerala, and certain indicators were next to Kerala and Maharashtra. Mostly the RCH indicators and any other indicators. And but when compared coming to the vaccination perspective, only vaccination, not an immunization, only vaccination perspective, we've been graded as the one of the low performing states in the initial stages when the Honorable Prime Minister and Honorable Chief Minister of Tamil Nadu started the vaccination on January 16th. Till May, we had a lot of challenges, and as per the challenges, always Tamil Nadu was graded as one of the last performer in vaccinations, especially in COVID vaccination. And this entirely led to there are many other issues also which I'm going to say here. And all vaccinations in the country is only voluntary, that is not made mandatory. And we also many face many legal battles, because of which many people were having the cases in the court with saying that they're making vaccine mandatory and all. So it's vaccination is voluntary. So the entire term, what we said is voluntary, made the people of Tamil Nadu to choose the right that vaccination is voluntary. It is not a mandatory one. So do not force me for vaccination. So this is the first challenge which we faced in COVID vaccination. Then came the vaccine hesitancy. Vaccine hesitancy said that I don't want vaccine. Why should I wear vaccine? And of course, in the literacy in Tamil Nadu and Kerala raised a few other initiations that they all came out saying that the safe vaccines are with 5 years trial, and these vaccines have been obtained within 1 year. So why should we make the guinea pigs? So why should we go for this vaccination? And then a lot of WhatsApp media, social media challenges regarding those that avoid vaccines, avoid vaccines. And then came the system called, then came the challenge called vaccine avoidance. Once the peak of first wave and second wave subsided, people thought that COVID has gone, and of course there is no impact of COVID hereafter. So why should I have vaccines? Then came the change of vaccine avoidance. So first is vaccine hesitancy converted into vaccine avoidance. And of course, this vaccine avoidance is very difficult for us to tackle it, because in the initial phases, when the peak of first wave and second wave, there are incidences in Tamil Nadu where they got vaccinations by standing in a queue. Even the queue was just like a railway ticket booking. They were making the queue with overnight also. There are media reports saying that people are waiting in the queue for getting vaccinations. But the entire scenario changed from that scenario to none of them coming for vaccination after the second wave submission. Second wave. So this was the main challenges what we faced. And again the adverse events following immunization. Every immunization we have certain events. Not
Sir, sorry to interrupt you. We have another 2 minutes.
Yeah, adverse events following immunization. So this was the main issue which we made this activity to go with. And again, media helps and vaccine wastages. And this again, on the innovation that address the challenges. This all led to a system of vaccine. What is the innovation? What we try to do is COVID vaccination. First is this vaccination workplace. Then we had this mega camp vaccination. Then we had this door-to-door vaccination. Had this campaign been innovated by government of Tamil India. And then school vaccination is one success in Tamil Nadu. And then standalone vaccine centers and the implementation of Public Health Act 1939. So the industrial vaccination, we know that large pool of people are migrant population from Bihar and Orissa. So we concentrate more on the industrial vaccination. We had a coordination with the district industries department as well as the CSR funds. We try to pull out the CSR funds, and we were able to motivate. And then we deployed all our mobile medical units to get vaccine for industrial vaccination in those centers. And then what led to mega camp? I told you that already we have an average of 61,000 mega camps. So average doses the initial first 16 to May 7th. Later, we thought this is a very low performing state, and when Government of India reviewed on 24th of August, we have only 50% of first performance, and the second was only 30%. So the consensus reviews by the Honorable Chief Minister and the respected Health Secretary and Chief Secretary led to us to start this a people's movement of mega vaccination camps. So that then we termed what with the idea is about making the vaccines available at a convenience and accessible both in terms and place and time for them. At any time they want, and on Sundays they're very free. So Sundays they have the camp, and from morning to 7 to 7 p.m., 7 a.m. to 7 p.m. See the operation strategies, we try to concentrate more on setting of booths. We just implicated the same aspect what we're doing the pulse polio immunization, setting of the booths, all the booth arrangements. We have interdepartmental coordination with all the departments in the districts, and then the manpower. We all use one vaccinator, one person for data entry, all through resource mobility and not nothing on new hiring basis at all. All the resource mobility. We involved all the local government, local self government, as well as the revenue department, intersectoral departments, ICDS department, everyone interface, and we have conducted 38 mega camps out of 52 weeks. We have 1 year, 52 weeks, and in the 1 year period, we done with 38 mega camps on all Sundays and Saturdays. And all of we are because of police protection, vaccine lodges were taken care of, and also the supervision. We all any vaccination we need a supervision. So one super is assigned to 5 to 8 booths. And IEC was a major part. We got money from NHM, and NHM supported with a lot of funds for us. And we made a all public announcement through auto announcements and through elected representatives. All the IEC and social mobilization is happening, and also we try to have the BCC. We know about IEC, but we want to implement a BCC strategy, that behavior change communication. So when I'm 18 years above, when vaccines are free, let me get vaccinated. So vaccination only not for safety, they're also for the family safety and for community safety, societal safety. We involve the NGOs also, and Rotary NGOs and other NGOs made a played a major part in this innovation activities. And intersectoral coordination, just I told you, all the ICDs departments, education, social welfare, transport, everyone were tied up with the help of the district magistrate. And we have a constant district task force committee meeting where all the line department were called upon, and they requested to coordinate with us for us this activity to be completed. And all the training activities and the district micro planning we concentrated, and the supervisor training also we done, especially for the COVID portal as well as the Google Sheet updations. And with instructions of booth, we started this booth from 7 a.m. to 7 p.m. There are lot of hard sticks for the field staff, but in spite of the hard stick, our field staff had done a wonderful job in having this 7 a.m. to 7 p.m. all Sundays. Sundays to be a holiday for them, but they have all the vaccination camps on a Sundays from 7 a.m. to 7 p.m. And then the contingency plan, we already allocated 500 rupees as a contingency amount for them. And information education banners, we supply about banners to all the booths. And this is a performance. So the from 61,441 average doses per year per doses, we moved to 2 lakh 17 doses per day after the mega vaccination camps. And the wastage we reduced from 6% to point 0.7 minus 0.7%. So the performance mega camps, out of 50% of total vaccinations, to 5.51 crore vaccine doses out of 12.76 crore vaccination have been completed only in mega vaccination camps, which has proved a real success for us. And also we improved the percentage to 99.66 percentage. And these are the slides we showing the various mega camps percentage. We have very when the initial mega camp was started, we vaccinated more than 30 lakhs on a single day. On mega camp date September 12, 2021, we vaccinated more than 28 lakh vaccinations on the single day. And later there was a ups and downs, and ultimately we are done with the 7.7 lakh vaccinations on the 30th mega camp. And these even the mega camps, we had faced challenges, inadequate funds for the mega camp, because we need to maintain these camps for 38 long weeks. So we are, although the NHM has suffered with funds, there are some lacking of funds, but we try to manage with the other CSR funds and other representation from other agencies also. And of course, there is a system fatigue, because working from 7 a.m. to 7 p.m., all the VHNs and all the village and field level staff have been much fatigue. And now, right now, we just now stop the mega camps at present. And management of AFA cases because vaccinating in 30, 28 lakhs or 7 lakhs, 8 lakhs, the equally reported case will be AFA case also for us. We try to manage the AFA cases, and of course there are few 43 untoward incidents reported, and then they've been managed here. And again, the innovation number 3 is about Others as campaign. We started on 10/11/2021. We asked the people, once the mega camp vaccination was going down, and also when the people are not coming to the camps also, we tried to move the field beneficiaries to the houses. Although we have the vaccine potency will be lost when go to houses, we termed it as a near to home. For example,
Sir, I request you to please conclude now.
yeah, final slides. And then finally, and we had the lesson 2 campaign was started 1/6/2000, June 2022. We were able to cover more than 5 lakh doses. And innovation number 5 is about school vaccination. We have Tamil Nadu, we have more than 850 RBS kit teams. With RBS kit teams and school nodal officers, we are able to converge with the school department. We are able to convert all the first dose 12 to 14 years and 15 to 18 years vaccination beneficiaries. And all the last one is the state and standalone vaccination centers. And we have this regular staffs going the other regular activities. We don't want to compensate on the regular activities going on happening in the system. So we already hired some certain standalone vaccination centers, vaccination vaccinators, which they all not only do the vaccination perspective, but also they're taking the swabs for the COVID vaccination, COVID perspective. And finally, the implementation of the Public Health Act. We have a Tamil Nadu Public Health Act, a robust public health system in 1939. We try to implement this, enforce this Public Health Act, making the vaccination near mandatory for them, so that we're able to improve the performance of vaccination. And that's it. And no, I mean, finally, I would just want to say that no one is safe until everyone is safe, and we're done with this. And above 18 years population, we are done with more than 97% of first dose, and about 92% of second dose, and above only just lacking in the 12 to 14 years, 15 to 17 years of second dose, which we're trying to complete it. Thank you.
Thank you, Dr. Vinay. And I think this is the collective power of our efforts, that as a nation, we have proved that it is possible through public-private partnership and ownership by individuals. In fact, I was very much impressed by your mega campaign, which in fact boosted the immunization program as a whole. So excellent work, sir.
Thank you, sir. Thank you a lot. Thank you a lot, sir.
Thank you, please.
Very good and novel work which you are undertaking, and providing vaccination is really help the world to contain this epidemic. So all the best to you, and thank you. No specific question to ask.
Thank you, sir.
Visible, ma'am.
Yes.
Visible.
Respected jury, very good morning to one and all. I am Dr. Devi Meenal, Professor Head, Institute of Radio Diagnosis, Government Kilpack Medical College. I am honored to represent here on behalf of the institute to highlight the outstanding work done by our team in digital mammogram and contrast mammography for the prestigious award. The facts that I am going to share with you today is all about how KMC Institute of Radio Diagnosis has saved 390 lives by screening over 11,000 cases by mammogram and detecting breast cancer at an early stage in the past 4 years, and is continuing to pioneer in women's health and inspires all breast clinics in the world. Digital mammogram with contrast mammogram. What is a mammogram? It is an image of the breast taken by the X-ray exposure, low energy X-ray exposure. This is a 3D digital mammogram machine. We keep the breast in this black plate, which is a detector, and the X-rays are exposed from above and an image is taken. Then we rotate the machine to 45 degrees and then taken another picture. So each breast, 2 images are taken. So for both the breasts, it is the 4 total images are taken and displayed in this format. This is a digital mammogram found in all the places. So what is unique here? It is the contrast mammography in KMC Institute of Radio Diagnosis. What we do here we inject the contrast and take the same pictures. The machine takes the pictures in sets, one low energy and one high energy, and the machine itself subtracts the images and gives the final information, and that's been made as a film, and we give a typed report with the international standard and a prop cover equivalent to a corporate sector. So what is a digital mammogram? What is a contrast mammogram from the pictures point of view? This is a digital mammogram. This is there in everywhere actually. So you have 2 suspicious areas. But this is a contrast mammogram. What has happened here? This has taken 2 pictures and subtracted the total breast tissue. So I am seeing only the lesion here. So the lesion is seen so well here. So this is less than a 1 centimeter, even less than a 1 centimeter mass can be picked up easily. So that is the main advantage, and we can say with 100% confidence whether it is a benign or malignant. Why detecting it so early is important. So the uniqueness of the nomination is detecting the malignant mass lesions, which is less than 1 centimeter with 100% confidence. So what is the impact it gives? So as it is detected so early in the stage of T1, it conserves the breast and gives near normal life expectancy. So you are conserving the breast and the patient is given near normal life expectancy, and it prevents all the breast cancer mortality. So we face so many challenges and how we overcome that actually. Breast cancer, as all of us know, people think it's a social stigma, and the patient presents very late in the stages with a fungating mass, where the mortality is very high. So what we did, we started doing quite a lot of awareness camps in the media and in the TV, the dailies, and then by multiple interviews. And we have also given a YouTube video awareness actually. And even though after creating awareness, how to mobilize the patient, there's a lot of difficulty from mobilizing the woman for the screening, diagnosis, even if diagnosed, then for the treatment and the follow-ups. So we use the Chennai Corporation City health workers, the paramedical staffs and the NGOs to mobilize the patients and to follow them up for the treatment. Then even if the patient is willing to come, then there's the cost involved from the diagnosis onwards. So we got a special government order to do mammo free of cost to the CMCHIS insurance patients and for the minimal cost of ₹1,000 to all other women. And we have got such an advanced machine, which has a 3D tomosynthesis, contrast, stereo biopsy. So it is first of its kind in Asia. So we had a difficulty in training the technicians and the doctors for this advanced imaging modality. So we arranged an international level conference in 2018, which was represented by Dr. Mindy from Italy and people from Malaysia and a few other countries. So they trained us, and then we started training all the newcomers of our department. And after diagnosing, still there was a problem in coordinating the teamwork between the radiology department, pathology, and the other treating departments like oncosurgeons and the therapy doctors. So this has been overcome by the regular interactions and the discussions. What is an excellence in KMC Breast Clinic? It's the pink infrastructure. It's a wonderful aesthetic pink infrastructure created by the government of Tamil Nadu and all the top level administrators, and the latest, the state of the art machine. That is the 3D. So normal, this is a digital mammogram. So all of us know it has a high resolution. It has a 3D. So I can see the breast in the volume. It has tomosynthesis. That means I can do a slicing, walk through each and every images. And then it has a contrast mammography, which I showed you previously, which can detect even less than 1 centimeter lesions. And added to that, we got such a big 12 MB monitor, and then a beautiful, wonderful, the state-of-the-art ultrasound machine, which has an elastography software. This software can differentiate benign and malignant lesions. We also had an MRI breast coil, and all this makes as a single umbrella to detect any breast diseases. And above all, we have a dedicated team with all lady radiologists and lady technicians. And above all is, whenever the patient comes, we don't give them an appointment. We don't give them any inconvenience. We make sure the case is done on the same day. We call this as a walk-in. For the past 4 years, we have followed this. And we do from the diagnosis up to the biopsy, and the treatment is done in a respectful manner. So I can proudly say the KMC Breast Clinic is the complete solution to any breast diseases. And we are continuing the awareness campaign. I have gathered few of the news clippings actually to share various milestones achieved by the KMC Institute of Radio Diagnosis in a chronological order. We started our first camp in 2015, February, using a conventional mammogram. It was inaugurated by the then Health Minister and the Minister of Textile and Handloom. The grand success of that camp made us thought of 3D digital mammogram. And the fully loaded 3D digital mammogram was inaugurated in 2018. And this is an international conference conducted in 2018, which was addressed by the then Health Secretary. And that was attended by people all over the world. The international faculties came for that. And then this has been upgraded with all other needs into KMC Breast Clinic in 2019, which was inaugurated by the Dr. Shanta, the director, the late Dr. Shanta. She was a director of Adayar Cancer Institute, along with 7 other then lady ministers in 2019. And within a year, an article was published in Hindu that 77 breast cancers were detected in KMC Breast Clinic. And we continued the campaign even during the COVID times. This is the campaign conducted in 2020. And in 2021, we made a 1 month long screening camp. And it was a mega camp. And it was inaugurated by the present Honorable Minister of Health and Family Welfare, and the Member of Parliament joined for the valedictory function. And to say, we could see 621 patients in this camp, and we detected 21 malignancies. This is almost more than double the workload, regular workload actually. And we have written a book, the world's first book on Atlas on contrast enhanced mammography. This is a new methodology. It's a new innovative methodology. So this is the first book, the Atlas on contrast enhanced mammography, written by us along with 4 other international authors, published by the famous publisher Springer. 2 of our assistant professors are doing PhD in breast diseases, and we have made an MOU with IIT to develop and evaluate the contrast enhancement curve pattern, thereby to differentiate benign and malignant lesion, which is not available in the world at present. And our work is being appreciated by the Tamil Nadu government with the best practice certificate. And above all, our department is being upgraded to KMC Institute of Radio Diagnosis, and it was inaugurated on 2/9/22 by the Honorable Minister of Health and Family Welfare. And back to the project as it is, the scalability and the replicability. We have the goal of screening all the women above 40 years. So first level, we wanted to expand to all the government hospitals and to continue the awareness campaigns using NGOs, political persons, and the celebrities. So now the patients are willing to come. Then how we are going to manage the heavy workload? The government and the project is planning to procure more digital mammogram machines. If it is going to be a 2D mammogram machine, which is going to cost around 1.5 crores. If it is a 3D with the contrast, it will cost around 2.5 crores. And for the manpower, you can utilize the same manpower available in the medical colleges, and then can give them an additional incentives for the extraordinarily good work done by them. And the future roadmap will be to make Tamil Nadu the model state in the breast cancer detection and the treatment. And we assume that it will get expanded to many states and the countries. Just to summarize the uniqueness of the KMC Institute of Radio Diagnosis, the KMC Breast Clinic, digital mammogram, and the contrast mammogram. KMC Breast Clinic houses the India's first fully loaded 3D digital contrast mammogram machine. Contrast mammogram is a unique technique to detect less than 1 centimeter malignant breast lesions with 100% confidence. We have done more than 11,000 cases and detected 390 breast malignancies. And early detection helps to conserve breast and near normal life expectancy to the woman. KMC team, by shortening the diagnostic time and no waitlist policy, ensured the benefits envisaged by the government and the rights provided for by the Constitution becomes a reality. The aesthetic pink infrastructure, the dedicated team reporting with international standards done on the same day of the patient visit is an example to all mammo units of this country and the world. It's the one-stop shop diagnostic facility for all breast diseases. We have proved government hospital is on par or better than any corporate sector in quality imaging. KMCradiology.com is our website, and the care, the sub-menu, if you click on, you can see the multiple care from 2014 onwards, the chief guest viewpoints about the hard work of the department. And in the award sub-menu section, you can see the achievements of all the students and the faculties. I can proudly say no postgraduate has left the department so far without a state or a national award. We have created and released a YouTube breast cancer awareness video, which can be seen from this link. And these are all the few news links which has talked about our breast clinic work. And I'm very much thankful for the SKOCH team for giving us this opportunity. And I would like to thank my dean and the present Director of Medical Education, FAC, for giving me this opportunity and continuously encouraging us. And my acknowledgements to all the top-level administrators of the Tamil Nadu, the past and the current Director of Medical Education, past and the current deans of Government Kilpack Medical College, all the faculties, postgraduates, and the radiographers of our Government Kilpack Medical College. Thank you very much for your patient listening. When you help a woman, you help the family. When you help the family, you save the society. So I request all the people listening to it today and the jury to become a pink ambassadors and start screening all the women above 40 years and give them a normal life, actually. Thank you so much for your patient listening.
Thank you, Dr. Devi Meenal ji. In fact, very good, rather outstanding work you are doing in this area. But as a matter of curiosity, you have detected 390 breast cancer cases. So what has been done to them? Whether amputation was done or it was removed through surgery or some radiography or chemotherapy was done? What has been the after treatment after that detection?
Yeah, actually, we have an oncology unit along with us, actually. So once it's been diagnosed, the patient's been referred to the oncology team, and then they take care of complete treatment, actually. And I have my Director of Medical Education and the present dean with me now. She also wanted to answer to you, sir.
So good morning,
Sure.
sir. I am Dr. Shanti Miller, President Dean, your Government Kilpack Medical College. I'm very happy to be part of this. I'm highly, thank you very much for this opportunity given to us. See, we have a oncology block as such under KMC. Based on these investigations, early detection of these cases, we have a tumor board, we'll discuss with the pathology team and the surgical oncology and radiation oncology team. Based on the stages, they will be shifted to either oncology, like radiation oncology or medical oncology team. Only if necessary, surgical oncology team will take over for surgery. So this is a teamwork, actually. Early detection by the radiodiagnosis department helps a lot of people coming to our hospital, actually. And almost all the patients are given a proper treatment, sir. And based on the stages, maybe stage 1 or stage 2, stage 3, like that. Stage 2 and 3, they'll be taken into brachytherapy, that is radiation oncology team will take over. Almost 80 to 90% of this population, they have a 5-year survival rate. Only the stage 4 cases with the therapy, almost 70% of the population, those who are detected with stage 4, 70% of that, they have a 3-year survival. This is the report as per our studies.
So
Okay,
thank
good.
you, sir.
the aim of the presentation itself is to detect in stage 1, and that can be possible by contrast mammo, and we have done like that for 390 patients, detecting in early. That is what I have been mentioning. That gives 100% near normal life expectancy.
Sure,
So
sure.
that's
sure.
the aim of the presentation.
In fact, it should be a matter of public policy that all women above 40 years of age should compulsorily, mandatorily go for mammography. It should be in our public health, public
That's what we are
policy.
creating.
Sure. Thank you, please.
Yes, sir.
Excellent
Yes,
work.
sir. Thank you. Thank you.
Excellent work and very technical presentation you have given. I wish you all the best. Thank you.
Thank you, sir.
Means wings. It means wings. So it is what we are presenting today is a community entrepreneurship model to prevent bonded labor in Tiruvallur. Bonded labor is something a major issue in our district, Tiruvallur district. The definition of bonded labor is a system of forced labor under which a debtor enters into an agreement with a creditor, an employee, that he would render service to him either by himself or through any member of his family or any person dependent on him for a specified or unspecified period, either without wages or for nominal wages, in consideration of loan or any other economic consideration obtained by him or any of his ascendants, or in pursuance of any social obligation. So this is a major issue. Basically, it is people who are forced to work for the creditors for some amount of loan, which is taken as an advance. And most of the time, the employees who are working, the debtors who are working as employees, they are not given proper wages. Sometimes they are not paid wages. Sometimes they are given very nominal wages. So many of the time they don't have freedom of movement. Many of the time they don't have proper accommodation, proper facilities, proper social security. Their kids are not getting education. So this kind of an issue is there. Majorly, it is not a problem which is limited to Tiruvallur district also, but since our district is close to Chennai and it is a very industrialized district with a large number of brick kilns and all that, we had this problem. So major sites where this issue is generally seen as in stone quarries, brick kilns, sari industry and construction sites. In Tiruvallur, it is mostly in brick kilns. So basically why it happens? Major reason is the lack of employment and lack of skills among the poor people. Mostly the bonded laborers are from particularly vulnerable tribal communities, tribal groups, scheduled tribes. From the scheduled tribe community, most employees are there. The high poverty makes them to get into a debt with the local contractor or with an employer, and they have to work for many years with the entire family, and they have to get they get very nominal wages for that. And when they ask for salary, they say that the employer say that so much amount is already we have loaned you so much amount, so you cannot get the wages. And there is a problem of EC credit in the rural areas, EC credit for the particularly poor people. So that is an issue. And immediate need of finance for multiple reasons, sometimes for health reasons, sometimes for any emergency, familial emergency. And that's at those times when there is a ready advance of money, the bonded labor system starts. So it is particularly this problem is significant in the district, in Tiruvallur district. So altogether in the last 5 years, 416 people were rescued from bonded laborers. So what we were trying to do is that, our initiative had two major broader points. One is to prevent the occurrence of bonded labor in the district. Second, to arrange for alternate livelihood for the people who are already rescued from bonded labor. Because when there is no such livelihood that is made available to them, there is a high chance that they are going again to the bondage. So these are the two things that we did, and what we did and how our journey started is what I'm going to explain in the next slide. Most of the bonded labor victims are from tribal communities, mostly Irulas, that is a particularly vulnerable tribal community in Tamil Nadu. That is, they are more vulnerable to this. So our initiative was that most of the bonded labor in Tiruvallur district happens in brick kilns. These are country bricks which are made in small factories. And for that, people are either transported from other districts or from other villages, and they have to work there for 14 to 16 hours in return of very nominal wages. So what we did is that we selected around 100 families who are already working in brick kilns as bonded laborers, as in a stage of enslavement. And through the support from the government, we created a community-owned brick kiln industry for them, so that once they were employees, now they are owners of that particular project. So it is a community entrepreneurship model involving 100 rural families. 40 families are involved in making of bricks, that is taking the earth, converting into bricks, putting it in the kiln, and keeping the kiln burning for the 40 to 45 days and taking it out and then stacking it. So that is a process. So 60 families are involved in wood cutting, because this process needs a lot of traditional wood. So that wood cutting is also quite a laborious process. For that wood cutting, 60 families are involved. So together, there's 100 families on this project. So that is what essentially the project is about. So these people, we were able to pay more than minimum wages to them, and dividend on profits also we were able to give. There is no bondage. They work based on their convenience and get paid for the work hours. Additionally, a share in profits also is given. So initially, they were working for some or the other middleman or landowner or a brick kiln owner in very primitive conditions. Now we have made them entrepreneurs, micro entrepreneurs working in a brick kiln sector. How we did it? We gave government land. We allotted it on a nominal rent. We gave them license for taking earth from a nearby reservoir. We gave a grant of rupees 5.1 lakh from the Tamil Nadu State Rural Livelihood Mission. Infrastructure support of around rupees 10 lakhs provided from MG and REGA. Equipments for wood cutting, because wood cutting also you need mechanical wood cutting machines, that we gave from the RD department. And there was a buyback agreement also. There is a forward backward linkage we were able to give. A buyback agreement we gave that, every brick that is produced in this kiln, we will buy for our PMIY houses. So around 4,000 PMIY houses are currently under construction. For that, we need a large number of bricks. So we gave a promise that this bricks, we made a promise and put into an agreement that these bricks which are produced will be bought back from them. So because of that, alternative employment for rescued bonded laborers was always been a challenge. Many economical activities failed. Previously in the last 5 to 7 years, many economical activities were tried. Most of the time it could not succeed because these were not matching the skill set of the laborers. Their traditional skill is in brick making, but rather than giving an industry in that particular skill, we were trying to give other embroidery or tailoring. So those kind of projects were worked out in the previously, but that was not getting desired success. So this particular two skills, brick making and wood cutting, was chosen due to the traditional expertise and experience. So this is what we have done to prevent bonded labor in the last 1 year. We created a task force to inspect brick kilns. Inspections by higher officials, including district collector, in all the 240 kilns. Visual display of a labor rights board in all the work sites. This particular board mentions the toll-free helpline also. If you can see in that picture, there is a toll-free helpline where the persons can reach out, the employees can reach out when there is a problem in the particular industry. So once we started raising these boards and asking we categorically stated to the employers that you have to mention how many people are there, how many people are working on a daily basis, what are the wages you are paying, what are the wages you are supposed to pay. All those things you have to write clearly in this board on a daily basis. We got a lot of compliance for our regulations. And regular meetings also we did. It's not just that it was a one-way communication. We discussed with multiple employers. We understood that what are the challenges and problems they are faced. They said that they have some accounting issues. They said that they don't have sufficient expertise in keeping of accounts. Then we organized a workshop to all the maestries and supervisors and accountants to advise them and to ensure that they are able to follow the regulations. And we started insisting on digital payments. Many of the time, what we identified is that during inspection of the registers and records, we identified that in record the payment is made, but it is not there originally credited to the beneficiary. So we started insisting on digital payments and maintenance of bank accounts, passbook, and dedicated helpline, as I already mentioned, that also started. And we started working with various NGOs in the district also. So altogether, we were able to bring in good compliance among the employers where bonded labor was erstwhile prevalent. So that is one part of the initiative. The other part is creating alternate livelihood for the people who are already rescued from bonded labor. As I was mentioning, around 400 people were rescued at various stages. Out of that, 240 people are belonging to Tiruvallur district. The 160 people are from other districts. So for the people who are belonging to Tiruvallur district, we are doing multiple livelihood programs. The first livelihood program is this brick-in factory. As I was mentioning, there was a interdepartmental coordination and a broad vision was created on what to do. And a location was identified during April month. Soil testing and other basic preparatory activities was done. The infra development started, and we did inauguration on 13th April. So they started selling bricks by June 22. And it was a very touching moment when the erstwhile bonded laborers who were enslaved and now entrepreneurs, they visited me and they gave the first brick that is produced in the factory to me. So that was a very touching moment for the administration also. This is what we did. I already explained. This is basically convergence of various schemes. It is not a new scheme. Convergence of various schemes and various departments through MNREGA, the Mahatma Gandhi National Rural Employment Guarantee Assurance Scheme. We gave a shed for 10 lakh. Through Rural Livelihood Mission, we gave a grant for commercial activity around 5 lakhs. Through the Pradhan Mantri Awas Yojana, we gave a buyback agreement. The NGO gave the technical support. The Revenue Department, Land Revenue Department identified the land and gave permission for cutting. The Rural Development Department gave the cutting equipment at free of cost. Tangitco made a temporary supply of electricity. And there is this particular species of invasive trees in Tamil Nadu, which is called the Sime Karuvelam. It is also known as Prosopis juliflora. So this particular invasive species was used to be was used for wood cutting. So this invasive species removal also, this was useful. This particular project was useful. This is a timeline, how the land was previously and how the process started. It took some time for us to construct the shed, but we had a temporary arrangement and we started brick making. And this is how it is as of now. This is a micro entrepreneurship, completely community owned, community operated, and it was very heartwarming to see the happy faces. So we called all the major core team of the project on Independence Day and gave them, felicitated them also. And the picture on the right hand side is a happy entrepreneurs on the background of our national flag. So basically from enslavement to entrepreneurship is the project. It's a trauma-informed approach. The entrepreneurs know what is the issue and what are the problems, and they are in a better aware to solve those issues. Upskilling the traditional laborers to make them entrepreneurs also is happening. It is not there, even though they are working in the traditional industry. We have made so many steps that their skills are upskilled and there is more use of machinery. This is a model to scale up. There is convergence between departments and initiated and funded by the administration. 3 community level groups, as I was mentioning in the previous slide, it is benefiting more than 100 families. And this is the on the pictures on the left, and the top slide is the stage when they were getting rescued from the brick-ins where they were working. And the bottom right pic is a pic that we took a couple of months back. The happy smiles, happy families, and the students are getting education. They are able to go to school. The government has given them housing also. So it is a very heartwarming moment for the district administration. A few testimonials, which I am not going to be speaking on detail. Essentially, what has been done in the beneficiaries onwards is what is in this slide. These are a few of the news coverages, what has happened, and this is covered by Indian Express. Most of the national and international media covered it. This is a story which came in a Tamil vernacular weekly called Ananda Vigada. Actually, appreciating this project, we got the Tiruvallur district got the Tamil Nadu Chief Minister's Good Governance Award also. So that was again on August 15, this award was announced, and it is again, it is an inspiration for the district administration to continue our efforts. So what we are doing is that we are working out a scheme to rehabilitate all these 249 members. The Seragigal 2, our second brickmaking unit is getting started now. And 249 people we have organized into 31 self-help groups now. And we are starting on economic activity for these people in the 7 categories as mentioned on this slide: embroidery, fishing, goat rearing, milch animal rearing, provisional stores, woodcutters, wood cutting, tailoring. So by this year end, we are ensuring that all the 249 members, 249 people who are rescued bonded laborers in the district will be having their own livelihood, and they will be able to ensure that the students are getting education and their families are taken care of. So that is what the district administration is working on. This is our second break-in which we are starting. The first one I already explained. This is the second one. We have just started it, and by next month we are confident that our production will start in this unit also. In Tirutani, these are the other steps which you have taken. We have started a brand called Serangal. On the right hand side, you can see the.
Sir, sorry to interrupt you. You have got another 2 minutes.
Yeah, I'm completing actually.
Okay.
So we have started a brand. The brand is again Serangal. As I was mentioning in the first slide, the name means wings. So we have started that brand, and the products. Their products, tea coasters, bamboo stands, they are available in e-commerce platforms such as Amazon. Block printed cloth materials and napkins are also made available. We have started the second brick manufacturing unit, as I was mentioning before. And some of the bonded laborers, they were working in fisheries related units. For them, we are starting a crab fattening unit. And mushroom cultivation is another thing which we are doing. And to make all these activities under single umbrella, a district level cooperative society is also being started. So altogether, this has been a very satisfying journey for the district administration. We were able to plug out the menace of bonded labor completely from the district. As we see on the first slide, after we started this project, since we were able to plug out all the grievances in the initial stage itself, the rescued bonded labor, that incidents of rescue need not happen. We were able to make all the industries compliant to the rules. That is one thing which we were able to do on one hand. On the other hand, we were able to create alternate livelihood for all the rescued bonded laborers also. And I think in the years to come, this model can be replicated in other districts also. Thank you.
Sir, very good project. In fact, I was also thinking that instead of in one district, why not to implement it in all the district of the states? Because many departments like NREGA, rural development, national livelihood mission, and all that is so many departments have joined hands. Then definitely we can check this menace from the country. It is really a shame to have such a menace in this country. So please go ahead with the implementing in other districts also.
Sure,
Thank you,
sir. This is a pilot which I have done in Tiruvallur district, sir. Actually, it has been taken note out by the state government also. So they are checking the feasibility in other districts also, sir. Thank you.
Other districts also in other states also. It should be such a possibility that it may be happening in other districts also of the country. So why not to implement it nationwide?
Sure, sir. Sure, sir. It is what we have done is it is a district level project, sir. We have converged all the departments and made this happen, sir. But this is implementable, sir. It is implementable and scalable in other areas also.
Definitely, it should be
Yes, sir.
implemented across the all states in the India.
Sure, sir. Sure. So thank you, sir. Thank you so much.
Thank you, sir. Very good.
Thank you, sir.
Yeah, I also fully agree with Mr. Sharma. As this type of problem should have been eradicated long back in India, but unfortunately, these things keep on happening. And your project is really wonderful and remarkable example of interdepartmental governmental coordination. So I also suggest you to give presentation to other states where this type of problem is still occurring, and you take up with your state government as well. And
Sure, sir.
I wish you all the best. I wish
Thank
you all
you,
the
sir.
best.
Thank you, sir.
Excellent work.
Thank you, sir. Thank you, sir.
Sri Vishnu. Yeah, shall I start? Yeah, I am presenting this on behalf of my collector, Dr. Vishnu. This is a work which was done in Tirunelveli district between 2020 and 22. This is ThaiCare Nellai, which is a data analytics dashboard that we have created for monitoring and tightening up the review and the monitoring process for maternal care. Tirunelveli, as such, Tamil Nadu is one of the front runners in healthcare, and of its Tirunelveli district, with a population of 17 lakhs, has a very positive socio-economic indicator and an effective health system. But in spite of all this, our maternal mortality rate was hovering around 85 to 114 during the last 5 years, which is higher than the state and the national averages. This is also a point of huge concern for the district collector as well as the health team in this district. And we had sat together for quite a long time looking into what were the reasons. Usually when a maternal mortality occurs, the first response of the health system was to huddle around the table and look out what went wrong in the death. But during the process, we understood one thing is, it is important that we huddle together when the woman becomes pregnant and not when the woman undergoes an adverse outcome. So we analyzed and found that there were issues in the health of the woman, the healthcare providers, the operation of the health system, and of course, socio-economic issues which are related to the community to which the women belong. So MMR was mostly a multifactorial disorder and did not have a single answer for the whole issue. Based on that, we had an analysis of the public health responses to antenatal care and the parturition. We found that there we have a issue that is the software called as a PICME, on which all the data was entered. The PICME was what you call as an interface in which registration of pregnant women happened, and the linkage of maternity benefit schemes was done, and also there was an integration with the CRS registry. But this system did not, was just purely a data collection system, did not have a comprehensive risk categorization. There was no actionable workflow or a feedback mechanism, and reports that were generated by the PICME system was basic, and it had no data analytics systems attached to it, and it had limited utility during the process of maternal death audit. With these basic analysis on ground, we did a situation analysis of deaths of mothers that occurred in 5 years between 2016 and 2020. And we came to understand that we need to focus on the woman on day one And it is not just about ordering the public health system to do X or Y, but to integrate all the stakeholders in the community, not only the public health. So with this in mind, the district collectorate, the public health system of Tirunelveli district, the Tirunelveli Medical College, which is a tertiary care center in Tirunelveli district, and the Model Rural Health Research Unit, which is a field research unit established by the Department of Health Research, Government of India. We all four of us sat together to make an analysis, and we prepared what was called as Thai Care Nellai, of which Thai means mother. So it was just a simple mother care in Tirunelveli district, or Nellai was a short form for Tirunelveli district. So Thai Care Nellai is a future-ready maternal health management framework which we have built on top of the prevailing PICMI framework, and by introducing administrative technological innovations to blur the traditional boundaries between the healthcare and in the various areas of the public health system. And this was presented to the state level healthcare authorities and to the CM's office. It has been appreciated quite well. And the process of translation of the benefits of this Thai Care Nellai is already on road. The Thai Care Nellai highlights was it has got an effective health risk categorization and early identification of high risk mothers, resulting in an automated targeted primary care prevention, where the software itself will alert the VHN, the medical officer on the area, the DMCHOs, the DD Health, and the officers in the collectorate to intervene when there is a high-risk pregnancy or wherever a low-risk woman starts moving towards a high risk. So we catch the high-risk women early. Then the next thing is we had a first of the kind automated risk flagging mechanism, which we developed. Our team of almost 10 specialists from Tirunelveli Medical College and the Public Health Department sat together, and we created a data analytics and AI-based flagging framework, where for even the smallest risk that is arising in the women, the entire team was alerted and the team was asked to respond. And for every response, there was what you call as a feedback that was taken. And to take this feedback, we created a control room where a couple of almost 10 counselors were there who called up the women on almost a weekly basis. And this monitoring was added on to the data analytics framework. So what happened is not only the data that was collected by the VHN, the data was collected by the social welfare, data collected from the PHC, data collected from the revenue department, data collected by the control room calls, all these were lined up in one straight line. And the data got analyzed, and the feedback based on the data was given back to all the stakeholders, including the pregnant women. So what happens? This related into a close integration of all the stakeholders who are related with the safety and health of the woman. And a digital case sheet was created as a part of the framework, which included the woman from the date of pregnancy to 42 days after delivery, that is the postnatal care area, and all the AN visits, pregnancy outcomes, PN visits, scans, ECG details, everything was lined up and they were set for analysis. So all this with the customized data analytics dashboard gave us so much amount of analyzable, discussable data that resulted in us bringing in our revenue, social welfare, and nutritional departments into the game. So what happened? What was purely a problem of the public health department and the medical tertiary care now became a multi-departmental affair, with the revenue, social welfare, and nutritional department also jumping in to support the pregnant woman. And this is just only a few of the shots of the dashboard. So this is a dashboard which the collector can see, the deputy director of health services, the dean of the medical college, the head of the OG department in the medical college, the medical officer in the PHC, the VHN and the ANM and the public health AN staffs. All these people had their own customized dashboards, which gave them statistics, as well as there were a lot of questionnaires which they need to answer when there was a woman on risk. And we did a risk categorization, and this risk categorization was not done manually, but the system itself did it and lined up all the risks and flagged the risks to all the stakeholders in the system. For example, this is just one example where for a AN visit, if the hemoglobin dropped beyond a level, there was a yellow or a red or a green flagging. And based on the flagging, the VHN or the public health staff in the PHC had to immediately respond, and the response has to be recorded in the system. And the response was monitored by the PHC medical officer and the DMCHO at the HUD levels. And if the response was not adequate, the medical officer had to go in and intervene. And if there still was inadequate, the medical college faculty had to look into the matter, mentor the medical officer or bring in the patient to the medical college for further analysis and treatment. So what happens? This continuous monitoring resulted in more data that was generated at every block level, at every village level. And this added to the stability and accountability of the system. And this was achieved by a constant training session we conducted for all medical officers, right from the medical college to the PHCs, all staff nurses in the entire system, the village health nurses. And this was achieved by the investigators in the Tirunelveli Medical College, who were the people who were arranging all that and putting in the data. So after this training was complete, we found that we had covered almost all the 52 PHCs and UPHCs in the district, 8 taluk and non-taluk government hospitals. The Tirunelveli Medical College itself was part of the connected network. And what happened was, in the earlier from that early PICMI framework, now that we found that we were looking at 4,600 high-risk mothers instead of the earlier 1,750 average number of high-risk mothers in the earlier years. And the district control room, which we had created for the thigh care, was calling almost a lakh, had made a lakh calls to these pregnant women over a span of 6 months. And we had all that audio data as well as the documented data from these women, which were part of the system for analysis. And the AN visit coverage rose to almost 83.68%. And we had almost 20,000 automated flags that were working inside the system for all these registered mothers, which was responded to by the VHN, the medical officer, the AN staff nurse in the PHC, the DMCH at the HUD level, the DD Health, the collector and his health team, the dean and the OG team at the medical college. All of them were working on it. It created a flawless or a seamless integration. And the major systemic outcomes was we have now put in place a cloud telephony-based psychosocial counseling for these pregnant mothers. And if there was an issue, we counseled the relatives of the mother, that is the mother and the mother-in-law, who were sometimes the major hurdles in ensuring the health of the pregnant woman. And we had created a real-time digital case sheet, which was capable to be reviewed by anyone in the health system. It was absolute transparency that we had created, and a unified reporting system with actionable insights, which are part of the report, which was created by the machine automatically. And this unified report was available to everyone from the HSC level to the collectorate level. So what happened? We had made all data regarding the maternal health of the woman absolutely transparent to the entire system. So there was no need for very loud and incisive or sometimes even obtrusive kind of reviews. What happened? The collector knew what was happening for every woman in the system. The DD Health, the PHC, DMCHOs, all of them knew what was happening for all the women in the health system in the district. And this data integration also was widened to integrate the social welfare programs like the nutrition special diets that were given for antenatal women. All this was also recorded. And so what happened? The review was not about public health. It was not about the medical health. It was all about the health, social welfare of the pregnant women. And finally, after almost 9-10 months of the entire work, the maternal mortality rate calculated on a month-to-month basis has fallen by 40% in comparison to the previous years. And this has been enabled by the seamless integration of all public health departments, all the line departments like the social welfare and revenue, and the collaboration and coordination of all these departments has enabled us to create customized treatment protocols and faster responses to maternal health. And a lot of lives have been saved. At this point, we are presenting this as a pilot, and we know that our pilot is succeeding. We have discussed this with the national NHM team of the government of Tamil Nadu. And this is being now poised to be presented to the government of India and under the DHR. But to call it as a big success, we are still continuing our efforts. We are tightening up, we are sharpening the data analytics frameworks, and we present this not as science, not as any kind of a social engineering, but this is an emotional answer to one question that has always been painful to us as investigators in the medical college. Why should a pregnant woman die? Because pregnancy is one thing that needs to be decorated and celebrated in this country, but women die because of a very celebrated cause. And any death that occurs to a woman needs to be taken seriously as a failure of the social system, and the health system needs to make a very fierce response to it to see that almost all the women who are avoidable causes of maternal mortality need to be saved in this country. I'm not talking about Tirunelveli, I'm not talking about Tamil Nadu, I'm talking about the women of this country who need very sincere social system answers. And this thigh care system is one step forward to tie all the ends of all the different departments in the government, which are individually acting to improve maternal health, but they need to come together on a data analytics or an or AI framework where they can all push for a safe motherhood for women in this country, sir. Thank you so much, sir.
Thank you, sir. Very good pointed presentation. In fact, your success of falling 40% MMR since launch of January 22 itself is an initial success. But your state is chronically or historically or with legacy has been with the state which has high MMR. You still have a long way to go. But anyhow, it is a good work. And particularly with the conviction which you have presented in your presentation is definitely and very encouraging, sir. It is an excellent and outstanding work. Please keep up the good work.
Thank you so much, sir. Thank you, sir.
Excellent work being done by you and your team. I wish you all the best. Thank you. No
Thank you, sir.
specific.
Thank you so much, sir.